Yes. I don't. I know. So, is my mic on? Am I audible? Okay, perfect. So we are all set. There's a nice lady here who doesn't understand what I say, but I'm going to try my best. So we are going to do a. I'm using the Alcon Centurion machine, and I will be implanting a trifocal from the Care Group. It's a triphobic HD lens, which is what I'm going to do. She has almost no astigmatism. She just zero point 0.3 astigmatism. And can you watch the cornea a little bit? So I'm starting now. I'm sitting at 12 o'clock position. Light ko dekho. So I like to put a Rexus marker. So this will give me a guide for a perfect size and centered Rexus. And I like to make 1 mm 22 gauge side ports because my instruments are usually calibrated to this size. Uh, Except when I'm doing femto. Otherwise, I always mark it. Yes. Look into the light, please. Light. Yes. So it is basically going to give me a 5 mm Rexus if I run it along the Rexus marker. If I want it slightly bigger, then I will make it run a little bit outside that. So then I'll get about a 5.1 or a 5.2. And if I make it slightly smaller, then obviously I'll get little less than 5, but this is marked for 5 mm. So she was a little uncomfortable, I think. You have to tell her not to move suddenly, huh? So I will try to remain inside the mark. So the advantage of the Rexus marker is that it gives you a well centered, well sized, and circular Rexus. So all three things, the shape, the size, and the centration will be as good as you can. And one Rexus marker will last you a lifetime, which means that you don't have to spend more than 2-3 thousand rupees, so you can get a good Rexus each time. And it's invaluable in a set because in all our sets there is a Rexus marker. Now I'll just do a small hydrodissection and try to get a fluid wave, and then I try to rotate the nucleus with this itself. So I've now mobilized the nucleus. No. So now we can, yeah. So I'm using the Active Sentry handpiece, which is what I love now because now it allows me to go at IOPs which are very low, as little as 20-25 millimeters of mercury, or 25 centimeters of IOP of 25. And it has really changed the way we. Can you put a little bit of lignocaine on top? Just put lignocaine. Perfect. Okay. So with low fluidics, the patients in topical are very comfortable on both the machines that I use, the Veritas and the Signature and the Centurion. I tend to use low vacuum, and my chopper is also designed to fit into a 1 mm side port so that there is little fluid leakage. So my side ports are calibrated to my instruments. That allows me to get good chamber stability. So, and I prefer to do a direct chop, as you can see here. Thank you. Yes, unless it is so soft that you can't chop it, but then even then I try to chop the endonucleus. Then I try to embed deep into the center, and even the softest of cataracts will have some kind of a small endonucleus which you can chop. No, I don't need it. So I love the Centurion's fluidics and I love its cutting ability. So when I have to do a hard brown black cataract, I love how the Centurion tip can easily cut through it very easily, even the hardest of cataracts. Of course, with brown cataracts, I sometimes prefer to do a femto assisted surgery because that allows me to use. I think the patient is moving a little bit. नहीं वो ठीक है. She's not getting pain. She just wants to move, I think. So the fluidics are excellent for these new machines, and patients usually are very comfortable. I don't normally see them moving. And even under topical anesthesia, you can have a very comfortable patient most of the times. Visco? No, I don't. Yeah, cortex. So I'll be using bimanual IA, and the bimanual handpieces are designed specially for me. Again, just like the Rexus marker, they are designed for me by Epsilon. Again, no financial interest. I don't get anything out of it. But these are both sandblasted, very finely sandblasted, and they are both 21 gauge. Sorry, 22 gauge, and that's equal to about a 1 millimeter side port. And in fact, off late, I'm using these newly designed Orolab side port blades, which are again customized for me to 1 mm, and they are very nice, nicely made blades, and they are reasonably priced, so you can throw them, discard them after every surgery. So you can see, yeah, so you can see that these are both hand pieces are designed for high flow, and they are sandblasted in a very fine way, so I can polish with either of them, and it makes life much easier. And I actually now like to polish with the infusion handpiece rather than the aspiration handpiece, because that does not allow the PC to get caught or damaged. So I'll show you something that I like to do nowadays. Rather than now go and aspirate this, I will go and put infusion under this here. So you can see that I'm doing passive infusion and I'm just letting the fluid flow. I don't know if it's well centered or not. So all I'm doing is I'm polishing with my infusion handpiece, and if there are any plaques or if there's cortex which is stuck in the periphery, it all gets loosened up, and then I'll just go under the rexus and also loosen up the cortex. So that makes it all detached, and now I can just aspirate very easily. It'll come in a moment, and you won't have any tags left most often, and it's all gone. I don't even have to switch my handpieces to the other side. So whatever is left, so this makes it's like a hydro procedure which allows you to clear it completely. Now I can put the lens. Yeah, thank you. So we are ready to implant this special lens, which is amazing. It's a trifocal lens, which has more than 92 to 93% light transmission, and allows you to have 50% is for distance, and about 30 and 20 for near and intermediate. So I'll see, because this injector I'm not used to using actually, and I'm going to see whether it allows me to do a wound assisted. It's a hydrophobic lens, so it should go. And I'm doing a hydro implantation. I don't use viscoelastic. So it's a beautiful injector, I must admit. Just see that. Very smooth injection under hydro. I mean, I'm only using fluid. So it's gone in nicely. It's a beautiful lens. No, give me a dialer or something. And once the lens is gone in, I can just nudge this lens inside. So all this is accomplished under hydroimplantation, though no viscoelastic, very controlled injection. And the advantage is that I don't have to remove any viscoelastic. There is little risk of TAS because no viscoelastic was used after my Rexis. So there's no residual viscoelastic inside the eye. And I'm leaving the lens in a supranasal infratemporal orientation, very well centered as you can see. Whatever little visco remains, which went with the lens cartridge, I'm going to remove that first. And then I'm going to just depress the posterior lip of the main wound, and that will allow whatever little visco is remaining anywhere to come out very fast, because I'm allowing a very high flow system over here. So it allows everything to come out, whatever is debris is remaining inside. Now I'll hydrate the wound. So again, for hydration, I'm using the Herschel Tuck cannula, which I've been using for the last few years. And see that my infusion is on from the left hand. So my chamber is always formed. I do a lot of torics, almost 70%. So I don't want my lens to move inside. So my infusion will remain on, and I will hydrate the wounds with the eye held with the IOL inside in a very stable chamber. So I am now hydrating the side ports and then the main port. So this cannula is, yes. So in very rare situations, I will do use viscoelastic. Like if I have a subluxated bag and I want very good control. There are situations where I will not do a hydroimplantation, as you said. If there's an open posterior capsule and I want a very very stable chamber and no fluctuations in the chamber, or I'm expecting any kind of a difficulty in my IOL implantation, so if I want the best possible control, obviously I'll go to viscoelastic. But then that adds a step of removing the viscoelastic, which itself causes chamber fluctuations, etc., and a lot of manipulations. So in a routine case, I would say that 98% of my cases. So you can see how beautifully this cannula works, and it gives you a perfect seal each time. So I'm a fan of this cannula actually. And you can see that the lens is beautifully centered. It's a wonderful lens, works from about 35-40 centimeters to about 65 centimeters, and very good patient satisfaction. I normally would put intracameral moxie at the end of the surgery, but I think here we don't have it right now. So I think we are through with the surgery. If there are any questions, I'll be very happy to answer. Thank you, ma'am. Thank you, Dr. Wonderful. And I must appreciate all the arrangements here at Agarwal Eye Center. They are fantastic. They keep getting better every year, although there's little to improve. But the whole staff, the doctors, and every arrangement is amazing. So thank you so much. And signing off.